We are live.
Good evening, everyone. Welcome to iFocus Online, lecture number 557 of Optics and Refraction module number 32. Today, we'll be talking about direct optics of direct and indirect ophthalmoscope, and the talk will be taken up by Dr. Shweta ma'am. The chairperson for today's class, Dr. Ubli Ramachandran sir, he has done his MD ophthalmology from AIMS New Delhi and his vitreoretinal fellowship from Arvind Eye Hospital, Madurai. He is currently the consultant and fellowship surgical trainer at Center for Sight. He has published 18 plus papers in national and international journals and presented videos and papers in multiple international conferences. He has received Best Video Award at OPL 2022 and 2023 and also in the Asia Pacific Vitreoretinal Society in 2023 Hong Kong. He has, to his credit, the highest number of surgeries performed in Center for Sight in 2024. He has also completed Advanced Management Program in Healthcare from ISB and has been selected in Dean's List for Academic Achievement. Welcome, sir. The moderator for today's class is Dr. Tushar Agarwal sir. He has done his long-term vitreoretinal fellowship from LV Prasad Institute, uh, the LV Prasad Institute. He has currently been in practice at since January 2021 in Center for Sight. He has published multiple national and international peer-reviewed journals and has presented at major conferences, most recent being a video presentation at 25th Euretina Congress Conference in Paris 2025. He is the member of AIOS, DOS and Vitreoretinal Society of India. He has been awarded with TP Agarwal Trophy for the best paper presentation in DOS 2017 and also postgraduate thesis award at AIOS annual conference in 2019. We welcome you, sir. The speaker for today's class, Dr. Shweta Singh ma'am, she has done her MS Ophthalmology from Kanpur and Senior Residency from Lucknow. She has done her clinical VR fellowship from Center for Sight, New Delhi, and currently she is consultant at Center for Sight, Agra. She has multiple international and national presentations to her credit. Her award winning work is on intravitreal clindamycin and biosimilars research. She has also been invited as faculty speaker at Retina Summit and AIOS platforms. She has a special interest in uveitis, retinal infections, and anti VGF research. Welcome, ma'am. Over to you, ma'am.
Thank you, Surveen, for the kind and humble introduction. Now I shall be sharing my slides. Is my slide visible?
Yes, ma'am.
Okay. Just a second. Okay. Good evening, everyone. Today's topic, the optics of instruments, direct and indirect ophthalmoscopy. Now, before we move on to the topic, let us discuss in brief about the anatomical landmarks. So the crystalline lens of the eye, it divides the eye into the anterior segment and the posterior segment. The anterior segment including the iris, pupil, cornea, lens, and the posterior segment includes the vitreous cavity, in which we see the retinal vessels, the retina, and the optic nerve head. So the term ophthalmoscopy is defined by two Greek words. Ophthalmo means eye and scopy means to examine or visualize. So it means visualization of the interior structures of the eye. Now this is a diagrammatic representation of the left eye fundus. Here the central zone is defined by the optic nerve head and the macula. Beyond that is the equator, which is the imaginary circle which is made by joining the vortex veins, ampullae. Between the central zone and the equator lies the mid-peripheral zone, and beyond the equator lies the peripheral zone. So the methods of ophthalmoscopy includes the direct ophthalmoscopy, indirect ophthalmoscopy, and slit-lamp biomicroscopy. So we'll be discussing about three of them in the coming slides. So let's begin with the history of ophthalmoscopy. It was long back in 1704 when the first recorded observation of the fundus was made by Jean Marie, who observed the retinal vessels in a cat's fundus by placing the animal underwater. Much later in 1822, Evangelista Perkinje, he described a complete technique for the ophthalmoscopy. And then later in 1847, Charles Babbage built a prototype ophthalmoscopic device. Now all these observations were not published. Then came the Helmholtz era. In 1850, Sir Hermann von Helmholtz, he invented and published the description of the first practical direct ophthalmoscope, which he called the Augenspiegel or the eye mirror. And after that, in 1915, Francis Welsh and William Noah Allen invented the world's first handheld direct illuminating ophthalmoscope. So remember these names as they have great contribution to the technique of ophthalmoscopy. Now, coming on to the history of the illuminating system, we have come a long way from using candles and gas lamps to using external bulbs and in-built bulbs. About the principles of direct ophthalmoscopy, the three basic principles were described by Helmholtz, the first being the most important principle of emmetropia. That means the observer and the patient have to be optically emmetropic. Second, the retina of the patient should be properly illuminated. And third, the light source and the observer's pupil had to be properly aligned along the same optical axis. So in the below diagram, if you can see, there's a light source, which is the light coming out from the light source. It is reflected inside the patient's eye by a mirror, which illuminates the retina. And this illuminated retina is then observed by the observer. So all this is happening in an emmetropic system. Now, what happens if the patient's eye is myopic? Remember, a patient's eye myopic means the eye has more power. So the rays which are coming out from the illuminated retina of a myopic patient's eye are converging. So they tend to focus in front of the observer's eye, that is in front of the retina of the observer's eye. So to make them focus at the retinal surface, we need concave or the concave or the convergent lenses. Right. Now, about the hyperopic patient's eye, the hyperopic eye has the lesser power. So the rays of light which are coming from the hypermetropic eye, they are divergent. So we need more converging lenses. That means the convex lenses, so that these rays of light can fall or form an image at the patient's at the observer's retina. Now, how the working of the direct ophthalmoscope is? We have a light bulb, which is a light source. Then we have lens 1 and lens 2. These two lenses then converge the light which falls on the mirror. Now, this mirror is placed at a 45 degree and it has a slit opening. This ray of light, these get reflected inside the patient's eye and they illuminate the retina. Now, the rays of light from this illuminated patient's retina, they come out and they get converged at the center of this mirror. And after that, they move out and fall inside the observer's eye. So the point where they converge at the center of the slit, the image formed is real and inverted. But when the image is formed at the observer's retina, what we observe is a virtual and erect image, which is unreversed. Now, all this happening in the head of the direct ophthalmoscope. So, what are the parts of the direct ophthalmoscope? We have a patient side, which is the front side, and the doctor side, which is the back side. So, the front side includes a mirror, we just talked about. We have the aperture selection wheel, and then we have the lens selection wheel. This head is detachable and it is over the battery compartment. Now, talking about the doctor side, we have the brow rest, we have the doctor's eye window, and the lens indicator, which tells us what is the type of lens we are using and what is the power of the lens we are using. We have the on and off button also. So all this is happening inside the head of the direct ophthalmoscope. Let's talk little about the lens wheel which is also known as the Rekos disc, named after the ophthalmologist who invented it, and the aperture wheel. Now, this lens wheel consists of multiple compensatory lenses. These compensatory lenses are used to make the whole system emmetropic so that the retinal image can be formed and observed by the observer. And this aperture wheel, it increases or decreases or changes the size and shape of the light beam falling inside the retina of the subject. Now, the technique for the distant direct ophthalmoscopy, it is done at an arm's distance as shown in the left picture. Now, the right picture shows how the normal red glow looks like. Now, this red glow gets altered in some conditions like media opacity. So, any opacity in the optical system, be it a corneal opacity, any anterior chamber debris, lens opacities or vitreous opacities, or any retinal pathology like a mass, tumor, or retinal detachment, can alter this normal red reflex. So the below pictures, they show how the red reflex is altered in the cataract and the white reflex or the leukocoria in patients of retinoblastoma. Also, in cases of high anisometropia, the eye with the highest refractive error also shows an altered red reflex. After that, after doing the distant direct ophthalmoscopy, we go on to the direct ophthalmoscopy main method. So for the direct ophthalmoscopy, the patient's pupil have to be better dilated. After that, give patient a fixation point straight ahead. Then look through the eyepiece of the ophthalmoscope to the red glow of the center of the pupil and go as close as possible to the patient so that the retinal details get visualized. Now remember the rule RRR and LLL. The right eye of the patient has to be examined by the right eye of the examiner holding the ophthalmoscope in the right hand, and converse for the left eye also. So when you look into the fundus of the patient, this is how the retina will get illuminated. It's a small patch which gets illuminated. So trace the blood vessels to the disc, examine all of the retina, and then examine the macula at the last, because it will get uncomfortable to the patient. About the image characteristic in the direct ophthalmoscopy, I just told that the image is virtual and upright. It is highly magnified, that is 15 times. The field of view is less, that is 15 degrees. The larger areas can be examined by tilting the viewing axis. The working distance is very close to the patient, about 2 to 3 centimeters. And because it is a uniocular procedure, so no stereopsis. So we don't get a better depth perception. So what to do if we have to examine the structures which are at a depth or at an excavation, or structures which are elevated from the retina? Here is the use of compensatory lenses. So lenses have a color coding. The positive or the plus lenses or the convex lenses, they are green in color, and the negative lenses or the concave or the minus lenses are red in color. So first look at the central picture. If we want to visualize the retinal surface and the retinal blood vessels, we use neutral numbers, considering the whole system being emmetropic. Now, if we want to examine the structures which are at a depth, like excavated structures like the cup of the disc or any staphyloma, we need that the rays of light should be focusing beyond the retina. So here we use the minus lenses. And if we want to examine the elevated structures like the neuroretinal rim or any granuloma or any papilledema, we have to make sure that the rays of light are falling before the retina. In that case, we use the positive lenses. Now, about the use of different apertures, we have large aperture, which we can use in the fully dilated pupil, medium-sized aperture for mesopic pupil, and small light aperture for the constricted pupil. Now, half-light, you must have also seen the half-light or the D-shaped aperture. This D-shaped aperture is used in the presence of media opacities, like if there is a sectoral cataract, we can use this half-light aperture. Now, why these apertures? Because if the light will strike the edge of the pupil, there would be a lot of reflection and we won't be able to focus this at retina. So fully dilated pupil is a must for using while doing direct ophthalmoscopy, and the different size of aperture can be changed accordingly. Now we also have different color apertures. First is the red free light, we have a slit, the blue light filter, and the grid. So what is the use of this red free light? This is used to examine something red, like the blood vessels, the retinal hemorrhages, and the microaneurysms, which are very subtle and we can easily miss them. Also to detect the RNFL defects, because here, when we see the retina through the red free light, the red blood vessels, they appear dark. So a better contrast is seen. Now the slit is used to detect any macular pathologies, like in the presence of a macular hole. If we project the slit over the macula, the patient might experience that the slit is being broken. Now about the grid is essentially used to detect eccentric fixation. We ask the patient to look directly into the light of the ophthalmoscope, and if the center of fovea is not matching with the center of the grid, that means the patient has got eccentric fixation. It can also be used to detect the size of the lesion, but generally the size of the lesion is being named as in this diameters. We don't actually use the grid, but yes, this diameters are more important. Now about the blue light filter, it is like a handy filter wherever we are using the fluorescein dye, like to detect the corneal defects or leaking blebs. Here we can use the blue light filter. About the field of view and magnification, the area of the retina that can be seen at one time is called the field of view. And this view depends upon the size of the slit hole aperture. We just discussed we have different sizes of slit apertures. So the greater the aperture, more is the field of view. The second is the observer's pupil size. Like I am examining the fundus of fundus of a patient, then if my pupil is dilated, I'll have a more field of view. But practically, it is not much possible. And also about the refractive status of the patient. The field of view is smaller in myopic patient and larger in hypermetropic patient. Now, how this refractive status of the patient affecting the field of view, I'll discuss in the next slide. Now, remember one rule. The more the magnification, the less is the field of view. And remember one more formula. The power of I divided by 4 gives us the magnification. Now, the power of I is taken as 60 and divided by 4 will give you 15 times. So, we just discussed that the magnification of a direct ophthalmoscope is 15 times. Now, in case of myopia, the power of the eye is more. It will be more than 60, 61, 62, 65, or even 70. So this higher number divided by 4 will be more than 15, definitely. So in myopia, more the magnification, and we just studied the rule that more the magnification, less the field of view. So in myopia, we'll have more magnification and less field of view. The converse is for the hypermetropia. The power of the eye is less. That means this number won't be 60 anymore. It would be less than 60. So less magnification and more field of view. Okay. Now that was about the standard direct ophthalmoscope. Let us discuss a little bit about the newcomers, that is the Panoptic and Panoptic Plus direct ophthalmoscope introduced by Welsh and Allen. And they come with the eye cup. Both the pictures, as you can see here, they are fitted with the eye cup. This eye cup stabilizes the image and maintains the viewing distance. So distance means these can be operated at a distance. We need not go as close as possible to the patient. So advantage, these Panoptic and Panoptic Plus, they give us a greater field of view. As shown in the picture below, the standard ophthalmoscopic view is only 5 degrees, but here the field of view is enlarged to 20 times. Okay, it is less affected by media opacities like cataract, and it requires minimal or no pupil dilatation. And if we talk about Panoptic Plus, which is the latest system, it allows the connection of smart devices to capture the images of the fundus. Like shown in the lower picture, we can see the Panoptic Plus ophthalmoscope has been fitted with a smartphone, and we can make the video of the retina examined, and we can even zoom in and zoom out. So this is an additional advantage which comes only with the Panoptic Plus direct ophthalmoscope. Okay, so if we summarize the features of a standard direct, Panoptic and Panoptic Plus, few points. First one, field of view. Definitely the field of view in direct ophthalmoscope is lesser. In Panoptic Plus, it is 5 times more, that is 25 degrees. And in Panoptic Plus, it is even more than that, up to 100 degrees. The magnification is 15x in the standard one, whereas in Panoptic and Panoptic Plus, it is increased by 26%. Where standard direct ophthalmoscope requires ideally dilated pupil, Panoptic and Plus can even help us examine the fundus in an undilated pupil also, where the working distance in standard is very less. Here in the Panoptic and Panoptic Plus, it is increased 6 times. About the illuminating system, the Panoptic Plus one uses a LED, and Panoptic Plus is the one which comes with an Eye Examiner Pro compatibility. That means we can connect our smartphones and then make a video of the retina. So that was all about direct ophthalmoscopy. Let's come on to the indirect part, the indirect ophthalmoscopy history. So it was long back in 1852 that Christian Root invented the first mono.
Ma'am, the presentation stopped. No, you're muted also.
Okay, so
You can reshare, ma'am, from the
I'm
main.
sharing.
Ji.
Will you please tell at what part did it stop? Right, was I on this slide?
Yes, I think this was where
The
this
slide
interested.
previous. The slide previous. Yeah.
The slide previous.
Yeah.
Okay, so
After this, the next slide. Yeah.
this one, the
Yes.
history of.
Yes. Yes. Yes.
Yes.
Okay, okay. I'm so sorry for the interruption. So again, I'll tell something. Yeah. Just a second. This slide, am I correct?
You stopped it. Can you just reshare it?
Okay. I'm sorry for this.
Yeah. Now your slides are visible.
All right. So we were discussing about the history of indirect ophthalmoscope. I'm very sorry for the interruption. It was long back in 1852 that Christian Root, he invented the first monoocular indirect ophthalmoscope. So it was monoocular that time. Later in 1861, Toulon, he invented the first binocular indirect ophthalmoscope. And much later in 1885, William Dennett, he demonstrated the first electric ophthalmoscope with an incandescent light bulb. So this is a very historical picture showing Theodore Root using a concave mirror for the indirect ophthalmoscopy. Now, about the modern binocular indirect ophthalmoscope, the credit goes to Charles Louis Gibbons, who in 1945 invented the modern binocular indirect ophthalmoscope with a headband mounted system. So this headband, which is very particular of indirect ophthalmoscopy, was invented by him. Now, about the principles of indirect ophthalmoscopy, it says, make the eye highly myopic by placing a strong convex lens in front of the patient's eye, and then following the Gulstrand principle, which says that the illuminating and the viewing beams must be totally separated through the cornea, the pupillary aperture, and the lens, but they must go and fall on the retina and must coincide to permit viewing at the same time. Okay, so the picture here shows how the different beams, like one the illuminating beam and that other two which is coming from the observer's retina, should be separated, and they must not coincide with the pupillary aperture. Now, about the illuminating system of the indirect ophthalmoscopy, we have come a long way from using gas lamps to tungsten filament, and now we have indirect ophthalmoscope headband system, which is even connected with fiber optic. So about the optical system of indirect ophthalmoscopy, we have to illuminate patient's retina. So there is obviously a light source. We use lenses to make these divergent rays of light parallel. Then there is a mirror. This mirror reflects the light inside the pupil, and this reaches the retina of the patient and illuminates a part of the retina. Now this illuminated retina, the rays of light come out through the pupil and they reach the handheld condensing lens, where these rays of light are then converged to form an aerial inverted image. So this image is the aerial one, and it is inverted and laterally reversed. We'll be discussing about the image characteristic later. But now our observer's eye system has to be made such so that we are able to observe this inverted aerial image. Now, this is made possible by this headband mounted periscopic system, which consists of few prisms. So this system reduces the normal IPD of around 63 millimeters to 15 millimeters. And this allows the viewing of this aerial image. Now, remember, because we are artificially reducing the IPD, the normal IPD of a human eye, hence our normal stereopsis also gets affected. So though we are viewing binocularly, means we are viewing through both our eyes, we are getting some stereopsis, but it is not as great as what we see with the naked eyes. Okay, so we just read that the rays of light coming from the patient's eye, they are made to converge by a condensing lens, and they converge at the foci of the converging lens. Now, in case of myopia, because the myopic eye has got more power, the rays of light coming from the patient's eye are already converging. So definitely the rays of light will be converging little closer than the foci of the lens. Whereas in the hypermetropia, they would be converging beyond the foci of the condensing lens. So to observe this aerial image, the observer's accommodation also plays a role. So you have to use presbyopic glasses if you have while observing this aerial image. Now let us discuss the parts of the indirect ophthalmoscope headband. We have the front window, and then this is connected to the eyepiece. We have aperture selection lever and the bulb. Now this bulb is connected to the battery. The brightness can be controlled by a controlling knob. Then we have the headband height adjustment knob and the headband size adjustment knob. So first wear the headband and then adjust it to your head so as to make that viewing possible. Now this condensing lenses which we use, they are double aspherical lenses. Asphericity is provided so as to reduce the chances of spherical aberration, and this maximizes the field of view and takes care of the edge distortion also. Now procedure for indirect ophthalmoscopy: face the wall, wear the headband, and adjust the IPD so that the light spot is well centered from both the oculars at arm's distance. After that, hold the lens with the less convex side to the patient. I just told that these lenses are double aspherical, so one side is more curved as compared to the less side. So the more convex side is facing the observer, and the less convex side, which is also marked by a white rim or the silver rim, faces the patient. Okay. Now holding the lens into between the thumb and the index finger, we examine the patient. So this picture to the right shows how the lens is held between the index finger and the thumb, and it is moved in up and down direction in order to focus the image. And in order to examine the whole of the retina, we give proprioception. Like we ask the patient to see in different direction, giving his thumb as the target. We can even use our finger as a target to make them look in different directions while we are examining the retina. So this is just a picture taken from e-ophtha, where it is shown like how the different quadrants and sectors of the retina are examined in all the direction. So what about the periphery? Yes, indirect ophthalmoscopy gives a better field of view, but sometimes some peripheral details are missed. In that case, we have to use scleral indentation. The most common method or the instrument which we use for scleral indentation is a thimble depressor. The picture is showing how it is held between the finger and the thumb. We also have different other named indenters like the Shockett's indenter, the O'Connor's indenter. We have the Spade's pediatric indenter, which is used in patients of ROP while we are screening them, and we have Origer's indenter. So you might be asked, like, what are the different indenters? So these are just the named ones. Now, how it works. So for example, if you want to examine the periphery of the superior retina, we ask the patient to look down as shown in the picture. Then we place the indenter in the orbital socket and press the sclera. After that, we ask the patient to look up. In this way, we are indenting the superior part of the retina. So in the below picture, this is a pictorial representation of how the indenter is placed. It is pushing the retina inside, which is then coming in line of our viewing axis. And this is how we observe the peripheral details. So about the image characteristic, in the indirect ophthalmoscopy, the image is real, inverted, and it is laterally reversed. The magnification is around 2 to 3 times. It is definitely lesser than the direct ophthalmoscopy, but the field of view is greater, definitely. It works at an arm's distance, so it is comfortable for both the patient and the observer. And while we are viewing from both our eyes, stereopsis or depth perception is present. This picture shows how the full image of the retina is formed in the condensing lens. Now, this image number A, it is showing the fundus or the pictorial representation of the right eye fundus. We can see there is a smiley present over the disc. There is a star present at the superior temporal arcade, and there is a triangle present inferior to the inferior arcade. So here, when we are observing the retina through the condensing lens, the B picture is formed, where the smiley is present upside down, then the triangle is present superiorly, and the star is present inferotemporally. So this is how the picture gets reversed and inverted. So while viewing through indirect ophthalmoscopy, you always have to take care of the orientation. This comes with practice gradually. So about the retinal drawing, we have this modified Amsler-Dubois chart, which comes with 3 circles. The inner circle marks the equator, the middle one marks the ora, and the outer circle is the junction of pars plana and pars plicata. And the different sectors or the different clock hours define the areas. So tips for drawing: invert the chart with respect to the patient, draw what you see, and remember the chart orientation is akin to the actual eye. Now what it means, I'll show you with an example. So this is the patient whose right eye has to be examined. So we are placing the Amsler chart like this way. So what we have to do is just rotate the chart like this. Okay, now examine the right eye through the condensing lens. A picture something like this will be formed, where we can see the disc is temporal and there is a yellow lesion present at the superior temporal arcade. Now draw the exact picture over this Amsler chart and then reinvert the Amsler chart. So this is actually the position of the lesion which is depicted, which is present at the inferotemporal arcade. Okay, so this is how the turning of the chart works. At the same time, suppose if we are examining the right eye of the patient from the right side. So here again, we will invert the chart. Now we'll examine the right eye. And if we'll see some picture like this, a yellow lesion present at the superior temporal arcade. Okay, so draw the same picture over the chart and then reinvert the chart. This will give you the exact location of the lesion. Fine. So remember the clock hours remain the same. For example, if you are examining the patient's inferior part, inferior retina, then ask the patient to look down and the image will be formed, would be inversed and laterally reversed. Also, to examine the periphery, we have to do indentation. Now, this is a picture. Picture to the left will show that there is a detached retina and something which looks like a horseshoe tear. But as we indent and see, the horseshoe tear becomes more pronounced. The edges get lifted. So this is how the indentation will help in examining and confirming the lesion which is present at the peripheral retina. About the retinal drawing, so some basic color coding we have to remember, like retinal arterioles, retinal hemorrhages, microaneurysms, attached retina, and hole or any break is depicted by red color. The yellow color depicts any exudate or retinitis. Then we have green color. Anything inside the vitreous is green. It can be vitreous bleed, vitreous opacity, IOL in vitreous, silicone oil in vitreous. Then blue color is for retinal venules, detached retina, and the outline of the break. Pigmented lesion with attached choroid are shown with brown, and ora serrata or some scars are shown with black. Like this picture is also taken directly from eOphtha. You can go and have it. Now about the field of view and the magnification. The field of view depends here on the patient's pupil size. So this picture will show like when the pupil is less dilated, the rays illuminating the retina, the zone of retina is small. But when the pupil is more dilated, the illuminated retina is larger. Also, the field of view depends upon the power of the condensing lens. Few commonly used condensing lens, we have 14D, we have 20D, we have 28D, and 2.2 pan retinal. So as the lens power is increasing, the field of view is also increasing. So 14D has a lesser field of view, around 30 to 36. The 20D has around 45 to 60. 28D has a greater field of view.
Ma'am, we have lost the connection. We cannot see the slides.
What was the last slide which you saw? Sorry for it.
Ma'am, can you please share again?
Yeah, what was the last slide which you saw?
You were talking
Yeah.
about the power of lenses for indirect ophthalmoscopy. 14 diopters, 20 diopters, 28 diopters, that one.
All right, okay. So this one, right?
Yeah.
Yes.
Okay. I'm so sorry for again, but I'll get. All right. So about, I was just telling that the field of view increases as the power of lens increases. Like 14 diopter will have a lesser field of view, and the 2.2 or the 28 diopter will have a more field of view. And remember that 20 diopter lens is the most frequently used lens. So must remember the field of view given by it is 45 to 60 degrees. Okay, now about the field of view in indirect ophthalmoscope, how it depends. It depends upon the distance the condensing lens is held from the eye. If the condensing lens is held too close, the peripheral retina will not get illuminated. So we'll get a picture like this, okay, where the field of view is limited. On the other hand, if it is held very far from the patient's peripheral retina, then again the peripheral retina image will not be formed. So we'll get a lesser field of view. So the proper position of condensing lens has to be defined, and it will gradually come with practice. Now, the field of view also depends upon the refractive status of the patient. The field of view is more in myopia and less in hypermetropia, and it can be easily explained by this optical diagram, where we can see the more area of retina is getting illuminated in myopia as compared to hypermetropia. Now, about the magnification of indirect ophthalmoscope, the magnification formula is 60 divided by the power of the lens. So it depends upon the dioptric power of the convex or the condensing lens. So the wider field will have lesser magnification in high powered lenses. So if we discuss the different lenses, the 14 diopter lens has the maximum magnification, whereas the 28 diopter lens has the least magnification. But if we talk about the stereopsis, the 14 diopter lens will have a full thickened image. That is the best stereopsis compared to the other lenses. Now, about the magnification, again, it depends upon the refractive status of the eye. In emetrope, the magnification remains the same if we move the image. But in case of myopia, the image is smaller when the lens is nearer to the eye, and the image becomes larger when it is away from the eye. Now, this is the optical diagram which is explaining how it is happening. I don't want to go into the detail. And converse is for the hypermetropia, like the image is larger when the lens is nearer to the anterior focus or the lens is nearer to the eye, and the image is smaller when it is away. Okay, so a little bit about the lens, the condensing lenses, and their clinical implication. We just read that the 14 diopter lens has the highest magnification. The 20 diopter lens is like a workhorse lens. It's the balanced lens with the standard stereopsis, better field of view, and acceptable magnification. But the 28 diopter lens, it has got the 58 to 69 degrees of field of view, and it is most accurate for using in ROP patients. Now, how and why, I'll discuss in the next slide. Also talking about the 2.2, it has got the maximum field of view. So the widest panoramic view of the retina can be attained by using pan-retinal 2.2 lens. Now, about the 28 diopter lens, something. The zone 1 in ROP is classified as twice the distance from the center of optic nerve to the center of the macula. Now, when the optic nerve is positioned at one edge of this 20 diopter lens, like as it is shown in the picture, the zone 1 border can be visualized at the opposite edge. So at an instant, we'll get to know what is happening in the zone 1 or zone 2 border. So this provides a practical clinical method to estimate its extent by which we can design or tailor the approach or management of a ROP patient. So that's why a 28D lens is the most accurate lens to be used in screening of ROP babies. Now about the advantages, definitely indirect ophthalmoscopy is done at a distance. So it is more comfortable for the patient as well as the doctor. It has brighter illumination, so it helps in viewing through hazy media and dense cataracts. Stereopsis is present, greater field of view, so we get an instant retinal picture. And also the peripheral details can only be seen through indirect ophthalmoscopy. Now, this is the table in which I have summarized the features comparing the direct and the indirect ophthalmoscopy. First, talk about magnification. Definitely in indirect ophthalmoscopy, we have low magnification, about 2 to 3 times, whereas in direct one, it is high, like 15 times. Now, field of view, it is widest in case of indirect ophthalmoscopy, whereas in direct, we have narrow to 5 degrees. In stereopsis, obviously we are using indirect ophthalmoscopy and we are seeing with our 2 eyes open. So we have stereopsis in indirect, whereas because direct ophthalmoscopy is a monoocular procedure, so no stereopsis or no depth perception. Hence, this indirect ophthalmoscopy is advantageous wherever the depth perception for assessing elevated tumors or depressing, like in case of cupping, is seen. About peripheral viewing, it is possible only via indirect ophthalmoscopy. With the use of direct ophthalmoscopy, we can tilt the lens and we can reach up to equator, but not generally beyond that. About the media opacities, the indirect has got good ocular penetration, so it provides a better view through the hazy media. A working distance is definitely more in indirect, and refractive error has got minimal impact on indirect ophthalmoscope. Orientation of the image, this is something which we have to take care, that in direct ophthalmoscopy, the image is as it is erect. But in case of indirect, the image is inverted and reversed. Now, something about the slit-lamp biomicroscopy. It is examining of the fundus of the eye by using slit-lamp. Here also a condensing lens is used. So here about the image we see is again real, inverted. The field of view is around 30 to 40 degree, and we have different types of lenses which we'll be discussing in the coming slides. Now here also the magnification formula being 60 divided by the power of the lens. Now here, because the lens's power ranges around 78 to 90, the magnification would be definitely less than 1, but we are combining it with the eyepieces of slit lamp. Hence, it can be increased by 10x or 20x or 40x, whatsoever is present in the slit lamp which we are using. Now, the slit lamp biomicroscopy, remember, we are not artificially reducing our IPD in case of slit lamp biomicroscopy. So, we have a better stereopsis than indirect ophthalmoscopy. Also, it is done in sitting position. So this is a pictorial representation how the image is seen in cases of indirect versus slit lamp. So in case of indirect, we are getting a better field of view. Whereas in case of slit lamp, we only see a slit image of the retina. We do not see the picture as the whole. So we have to examine every part of retina, asking the patient to look in every sector. And this way we have to create a mental picture of the retina. But in case of indirect ophthalmoscopy, we get the picture as a whole. But like I said, we are not reducing any IPD in case of slit lamp. So better stereopsis than indirect ophthalmoscopy. Okay. Now, what are the condensing lenses? Some frequently used condensing lenses include 78 diopter, 90 diopter, and the wide field, digital wide field lenses. So the static field of view is 81 degrees. The magnification is high in case of 78D, and this high magnification gives a better or detailed workup, especially useful in cases of glaucoma disc evaluation. Now, the 90D lens is generally used for screening, and it can even help in visualizing retina in cases of small pupil. And the digital wide field lenses, it has got a larger field of view, and it is helpful in pan-retinal screening. It has got the widest field of view, and it can even visualize up till aura. For here also, we have to ask the patient to look in different direction in order to visualize all the retina, the whole of the retina. So that was all for today. I'm highly thankful for iFocus for having me here. Right. Over to the moderator and the chairperson.
Wonderful presentation, Shweta. You very well covered all the concepts of direct, indirect, and slit-lamp biomicroscopy. And if I just outline what you discussed about, it
Yeah.
was first we discussed about the principle of direct ophthalmoscopy, the pros and cons of the same, and then the principle of indirect ophthalmoscopy and the advantages it has over the direct ophthalmoscopy, the relation between the power of the lens and the magnification and field of view, and then you talked about scleral indentation. So one thing I want to talk about is that it's very important to orient your mind to the image that you see in the lens while indentation and the side which is being indented.
Okay.
Because of the inverse image, many times you get confused while indenting that which quadrant you're exactly indenting. So take a few seconds to realize which part you're indenting and then continue with the examination. Then you talked about retinal drawing. It's very important to remember all the color codes. And then the relation between power of the lens and the field of view and the magnification when doing indirect ophthalmoscopy. It's very important because of the inverse relation. So as you increase the power of the lens, the field of view also increases, but the magnification goes down. Yeah, so overall, it was a very good class.
Thank you, sir. And sorry for the disturbance.
No, that's okay. Technical glitches are not in your control.
Yes.
Dr. Obli, you want to comment on something?
No, it was an excellent presentation. I was much of what is needed for the post graduation has been extensively covered, and I think most of the students, if they are able to see this before they go to the exams, most of the basic questions and basic concepts will be, most of the basic questions which the examiners will ask will also be covered. Good presentation.
Thank you, sir.
If possible, I just want to make a comment on the extension of this class. The extension of this class would be the biome that we use in microscope for retinal surgery. Shweta, can I ask you a question?
Yes, sir. Please.
You have any idea about the power of the lens used in biome? What is the power of lens used for surgery? And like there is a macular lens and there is the routine lens.
So about the field of view, I must tell it's around 160 and 50 degrees. But yes,
So again,
I will
if
still.
it's so if you talk about the recite lens,
Yes.
it's around 60 diopters for the macular lens and around 128 to 130 diopters for the wide field imaging, wide
Okay.
field viewing.
Okay, sir. Thank you,
Yeah.
sir.
So this is one thing that the examiner may ask that what is the power of lens in bio or the binocular indirect ophthalmomicroscope used for retinal surgery.
Okay, sir.
That's it.
Okay.
Shweta
Do you
ma'am,
have any questions in the YouTube channel?
yes, sir, we have a question. Actually, I was just about to ask that only. So, there's a question on direct ophthalmoscopy, which says, how do you overcome small pupils or mild media opacity during direct ophthalmoscopy for maximum clarity?
Okay, thank you for the question. What I do, I would increase the illumination to its maximum. And definitely, if it's a small pupil, we have to use the smallest aperture. And in cases of media clarity, I just discuss if it's a cataract. If it's a full dense cataract, then definitely no light can penetrate. But if it's a sectoral cataract, like a cortical cataract, then in that case, we can use the half D aperture. Sometimes we can even use the slit. I told that slit. Aperture is used to detect the macular pathologies, but if the pupil is very little dilated, or not dilated at all, or if there is lots of dense cataract, we can even use the slit to examine the retina. Some part of the light eventually goes inside the retina and it illuminates it. So put a maximum illumination and the smallest possible aperture, and also keep the room dark. I must have not included in the presentation, but the room should be dark enough. Sometimes this dark can also help in dilatation of the pupil to a little bit extent, and this comes with an advantage. Okay, so yes.
Thank you, ma'am. Another question is how do refractive errors in either the examiner or the patient affects the image clarity and size in direct ophthalmoscopy?
Basically, image clarity, like image would be blurred. Okay, so in that case, that's why the compensatory lenses are given. Definitely, it will correct the patient's or the person which is getting examined for retina. The patient's refractive error is only corrected by the compensatory lenses. So image will not be clear; it would be blurred. And for us, we have to use our corrective lenses if we are seeing through a direct ophthalmoscope. Yes.
Right, ma'am. So we just have two questions. If Tushar sir and Ugli sir allow, then we can call it a day.
Yeah.
Yeah,
Okay from my end. Yeah.
yeah, definitely. It was a good class. Great work, Shweta.
Thank you, sir. Thank you, everyone.
Thank you, ma'am.
Yeah. Thank you,
Thank you,
Shweta. Yeah.
sir.
Thank you.